In this video titled, The Utilization of SonoMe in the Emergency Room, we will explore the practical application of SonoMe in urgent medical situations, showcasing its efficacy for efficient and timely diagnosis. eFAST scan. A 35-year-old male has been brought to the emergency room following a traffic accident. He presents with unstable vital signs, and now CT is not practical due to situational constraints. The assigned doctor has decided to perform a fast scan to check for blunt or penetrating trauma inside the patient. eFAST is a vital ultrasound tool in trauma care, swiftly identifying fluid and pneumothorax for immediate decisions in unstable patients within the ATLS protocol. Despite its imperfections, it is crucial not only for early diagnosis, but also for continuous monitoring, enabling us to observe changes in a patient's condition in real time. Traditionally, the FAST exam involves RUQ, LUQ, pelvic, and cardiac views. The extended FAST adds a chest exam to detect trauma-related hemothorax or pneumothorax. Consequently, trauma centers commonly utilize eFAST, including lung scans for a comprehensive evaluation. Getting ready for an eFAST scan with the SonoMe dual-head transducer. 1. Power on the transducer and connect it to your smart device. Ensure that the display on the smart device is adjusted for optimal visibility, especially in bright emergency environments. 2. Convex-type transducers with a low frequency range and a curved surface are ideal for examining the interior of the abdomen or pelvis. 3. Ensure the convex side is activated by checking that the light is on that side. You can activate the other side by pressing and holding the power button. 4. In the SonoMe app, choose Abdomen. Under the preset section, select the B mode from the modes. 5. During scanning, you can freeze and unfreeze by clicking the power button. 6. It is recommended to hold the probe with the power button facing downward. 7. Before beginning the actual scanning, confirm that the indicator direction is correct. The patient is in the supine position. eFAST is conducted by assessing 6 specific areas. Let's start the eFAST scanning from RUQ. Position the probe in the mid-axillary line at the 8th to 11th intercostal space, with the indicator pointed cephalad. This provides a coronal view of Morrison's pouch, the interface between the liver and kidney. Follow the lower edge of the liver caudally to obtain a clear view of the liver tip, where fluid tends to accumulate first. Minimize rib shadows by slightly rotating the probe counterclockwise, directing the marker dot toward the posterior axilla for an intercostal oblique orientation. Slide the probe cephalad to visualize the diaphragm and check for pleural fluid. Obtaining the splenic view is often challenging. Place the probe in the posterior axillary line at the 6th to 9th intercostal space with the indicator pointed upward for a coronal view. To minimize rib shadows, slide the probe cephalad. Rotate it slightly clockwise, and point the indicator toward the posterior axilla for an intercostal oblique view. This offers a clear image of the spleen's lower tip and superior surface, where intraperitoneal free fluid may collect. A pleural effusion will appear as a dark stripe just above the diaphragm. Pelvic views are key for spotting abdominal free fluid. Place the probe above the pubic bone, slide slightly upward for a longitudinal view. A full bladder marks the border between abdominal and pelvic structures. In males, free fluid appears behind the bladder, and in females, it's in the pouch of Douglas, behind the uterus. Clotted blood in the pelvis looks gray. Detecting pelvic free fluid is challenging in males with an empty bladder but remains possible in females. For transverse views, rotate the probe 90 degrees, pointing the marker to the patient's right side. In these views, free fluid may appear behind the bladder or uterus, or near the corners of a full bladder. Position the probe in the subxiphoid region with the indicator toward the patient's right side, firmly angled toward the left shoulder. This view reveals the right ventricle adjacent to the left lobe of the liver, allowing easy recognition of pericardial effusion. To enhance image quality, increase depth, apply more pressure, and instruct the patient to take a deep breath. The subxiphoid approach involves placing the transducer sagittally to visualize the IVC entering the right atrium at the cavoatrial junction. Measure IVC diameter 2 cm below the cavoatrial junction during both inspiration and expiration. Normal expiratory diameter is 1.5 cm to 2.5 cm, collapsing to less than 50% during inspiration. In trauma cases, significant IVC collapse and a small diameter less than 1.5 cm indicate volume depletion. When using ultrasound to detect pneumothorax, place the probe in the 2nd to 4th intercostal space along the midclavicular line. Start with a high-frequency linear or standard curvilinear probe, adjusting depth to 4 cm to 6 cm. Orient the probe longitudinally with the indicator cephalad, using rib shadows to locate the pleural plane. Anchor the probe, observing for the sliding motion of visceral pleura against parietal pleura. If the sliding sign is absent, suspect pneumothorax. Comparing both sides may aid in assessment. Please ensure that we do not cease scanning after the initial findings and maintain continuous observation of blood, multiple increases, changes in heart function, etc., so that we can appropriately adjust the direction of patient care. Ultrasound-guided central venous catheter placement. The patient bleeds, prompting a quick eFAST ultrasound scan. The doctor identifies severe bleeding and the need for immediate intervention. Recognizing fluid loss, they decide to secure central venous access for rapid fluid delivery. Ultrasound guidance enhances the safety and precision of central venous access by providing real-time visualization, reducing complications during the procedure. Prepare for ultrasound-guided central venous insertion with the SonoMe dual-head transducer. 1. Confirm that the transducer is powered on and connected to the smart device. 2. Utilize the linear-type transducer for optimal vascular visualization. 3. Activate the linear side by pressing and holding the power button, ensuring that the light indicates activation. 4. In the SonoMe app, go to the preset section, select Vascular, and choose B mode. 5. Freeze and unfreeze images during scanning by clicking the power button. 6. Before beginning the actual scanning, confirm that the indicator direction is correct. Adjust the gain to ensure that the image is neither too dark nor too bright. For ultrasound-guided central venous catheter placement, start by using ultrasound to identify the anatomy veins, arteries, and nearby structures. This step is best performed before prepping. Utilize both short-axis and long-axis views to pinpoint the vein's location relative to the artery. Look out for issues like hypoplastic veins or underfilling due to hypovolemia. To precisely differentiate between venous and arterial vessels, employ color Doppler imaging and Doppler flow measurements, yielding detailed flow profiles. The SonoMe H5C10L features both B mode and color Doppler mode, providing comprehensive imaging and flow measurements suitable for thorough examination during this procedure. To verify vein patency and rule out thrombosis, apply pressure to the vein using the ultrasound probe to assess compressibility. Note that in patients with very low arterial pressure, the artery may also be compressible. To confirm vein patency and quantify blood flow in both veins and arteries, utilize color Doppler imaging and Doppler flow measurements. CVC placement requires aseptic measures with ultrasound guidance, including site prepping, wearing sterile attire, and covering the ultrasound probe. The application of a sterile probe cover ensures a secure seal over the transducer, making the process quick and effortless due to SonoMe's wireless design. The single operator technique optimally aligns the procedure by having the operator hold the ultrasound probe with the non-dominant hand, and advance the needle with the dominant hand. Throughout needle advancement, the operator consistently identifies the needle tip using ultrasound, employing either a short axis out of plane view or a long axis in plane view. Use real-time ultrasound to confirm that the needle tip is centrally placed in the vein before advancing the guide wire. After inserting the central venous catheter, initiate infusion by connecting it to fluids or blood as needed. As the patient's vital signs are stabilizing with the infusion of appropriate fluids, we move forward in their care journey. In the urgency of the situation, the combination of eFAST ultrasound scans and timely central venous access emerges as the key to effective emergency medical care, offering hope and a lifeline to those in critical need. Thank you for watching this ultrasound training video. We hope this content has been valuable to you as part of your critical care education.